After last night's reception, I thought I was at a revival meeting. But you know, that's really what it's going to take. We need to have the passion and sort of the revival mentality to revive this industry, and it does need revival. The folks in this room today, as well as others that we work with around the world now, are trying to transform the industry. As Helen said, we believe that there are three core components to that transformational process, including redesigning the way we deliver care for patients using lean principles, but also including how do we pay differently, how do we pay for value over volume, and then making all of this very transparent to our patients. So what I want to do this morning is really talk about some of the great experiments, some of the best learnings, and actually best practices related to these three very important topics in terms of the transformational process of our industry. But the first thing I'm going to do is tell you a healthcare story. And this is a true story told to me by Tish. Tish is an 80-year-old Iowa snowbird. And with her husband, she left the cold Midwestern Iowa winter to go to a warm and sunny state this year. Actually, they've been going to this warm and sunny state for the last 15 years. But this past February, Tish got sick in the sunny state. She couldn't eat, she felt nauseous, she started coughing to the point that she thought she had pneumonia. She asked Ted, her husband, to drive her to an immediate care clinic. This is the story of what really happened to Tish over that period of time. Let me give you some key points of Tish's ordeal. It lasted more than 3 weeks with stops in 5 different healthcare facilities. She was at 3 of those facilities more than once. She endured more than 20 needle sticks. She had surgery for an infection given to her by her caregivers. She received medications at the wrong time of day and medications that made her condition worse. She had medication reconciliation errors. Patient safety protocols were ignored. She had repeat scans and lab work because doctors didn't actually review her chart. She waited for hours multiple times, and her concerns and expressed wishes were repeatedly ignored. Now, this is her story. Much of it took place at a hospital that, if I told you the name, you'd recognize it as being one of the safest hospitals in America today. I'm not going to tell you the name of the hospital, but I'm going to ask you a question. Is this your health system? When Tish arrived at the immediate care clinic, she was given Levaquin and steroids, and she was given these drugs despite the fact that she most likely had a nanovirus. Back at her condo, she reacted badly to these drugs, and she experienced nausea and vomiting. She called the doctor, but he didn't call her back. After 3 days of feeling miserable, Tish asked Ted to take her to the emergency room again. She had not eaten or slept or taken much liquid, and the doctor had never returned her calls. In the emergency room, they hydrated her and then hospitalized her because her potassium was very low. They took several needle pricks to access her vein. While in the hospital, Tish asked nurses to look at her right elbow, which had a bad skin tear over the joint. But they didn't look at it. Tish has scoliosis and severe arthritis and takes medicine at night so that she can sleep. She uses her elbows to position herself in bed, and the wound on her elbow made it hard to do that. But nobody seemed to care. Tish was in the hospital for 2 days on this first admission, during which time she developed a urinary tract infection and was started on antibiotics. She was still nauseous when she was discharged. So after 2 days back in her condo, she became dehydrated again, and she returned to the immediate care clinic. The doctor told her to drink 8 ounces of fluids every hour and sent her home. Now, it made her nausea worse, of course. The doctor prescribed anti-nausea medication, which didn't actually work because she couldn't swallow it. She couldn't keep it down. So the next day, she goes back to the immediate care clinic, and the doctor hydrates her with IV fluids because she couldn't take any oral things. She asked about her elbow, but nobody actually looks at it. It had been 1 week now since Tish had first gone to the immediate care clinic, which she'd now visited 3 times, plus 2 trips to the emergency room and 1 hospitalization. She now had a UTI an elbow that was getting worse, had been on antibiotics, a steroid, potassium, an anti-nausea drug, and a half a dozen needle sticks. After 1 week in the system, she was worse than when she started. But back at her condo, Tish started to feel a little bit better for a couple days until her right arm swelled from around her elbow. She returned to the immediate care clinic and to the ER where the doctor called the hospitalist. Her right arm had swelled actually from her hand all the way to her shoulder. They wrapped it and tried to start an IV in her left arm. They assured her that the EMT on the floor in the emergency room could get a needle in while bouncing around in the ambulance. Of course, that didn't help Tish because she was in the emergency room. But he tried and failed, and it took 4 pricks to get the IV going again. She was hospitalized a second time, given 3 very strong IV antibiotics, seen by an orthopedic surgeon. She was labeled as a high risk for falling. She was moved to the surgical floor, but the information about her medications did not actually go with her. Her morning meds were given at night. Her night meds, which helped her back pain, were given in the morning. Tish has taken these drugs for years, and she knows what she takes and why. She explained this to the nurses, but they ignored her. She was very frustrated. She could not sleep without her pain medication. The next day, the surgeon comes in, decides to drain her elbow. Infected elbow, she had an abscess. By that time, she had had 3 more IV insertions go bad. She asked for an anesthesiologist to do the next one, but she was told that the anesthesiologist was not available. Her arm had become a pincushion. They kept her on the antibiotics after the surgery on her elbow while they figured out what kind of staph infection she had. They quarantined her room, actually. A nurse came in wearing a long robe, her head and shoes covered. A little while later, the cleaning man entered the room wearing no protective clothing. And in fact, the clinical techs came in without gowns. Then all of a sudden, the precaution was stopped. And she thought to herself, what if this bug had been MRSA? Another nurse was preparing oral medication when the nurse's nose actually started to drip. Tish asked the nurse if she was going to wipe her nose. The nurse turned, grabbed a paper towel, swiped at her nose, threw the towel on the floor. When she returned to it, and then returned to delivering Tish's medications. Tish asked her if she was going to wash her hands. The nurse moved the clean laundry that was sitting in front of the sink and ran her hands under the faucet and wiped them. Tish had noticed actually that nobody washed their hands upon entering her room, except for the person who actually drew her blood. The antiseptic dispenser, also behind the pile of clean laundry, was actually empty. Tish reported all this to the head nurse on the floor and another nurse in charge of teaching the technicians, and even though she was worried because as she described to me, she says, it takes guts to tattle on your nurse. Nothing changed. On the 4th day after surgery, Tish's daughter, Susan, arrived to help her mother, whose care had been transferred actually to the hospitalist from the surgeon. In fact, they wouldn't see the surgeon again for many days. Susan asked the hospitalist to talk to her husband, an internist, but the hospitalist refused, claiming a HIPAA violation, even though the patient had asked the hospitalist to call her son-in-law. Now, it had been 2 weeks since Tish had visited immediate care, which she had now visited 4 times. She had been in the ER 3 times. She had been hospitalized twice. She had had surgery on the elbow that she had asked medical staff to check during her first hospital stay, but they had not. She had been stuck by a needle at least 15 times. She had been on half a dozen oral and IV antibiotics and other drugs. After 2 weeks in the system, she was worse than when she started. By now, Tish had very little oral intake, and her medications were still being delivered at the wrong time. Despite her condition, the hospitalist told her she was ready for discharge. Tish had been, tagged a fall risk before, yet no one asked her about her physical home situation, her family's ability to care for her. She could not get out of bed or walk by herself, and she was weak and unable to use her heavily bandaged right arm. So at 10 a.m., the day of discharge, Susan asked to see the social worker for an assessment of Tish's ability to go home. The social worker evaluated Tish and immediately realized that home care was not a viable option. She recommended a rehab center. Tish was quickly dressed and readied for discharge. Her nurse rapidly reviewed all 20 medications with Susan, even though Susan didn't understand any of the medications, and then they waited. Hours passed. When Tish was finally discharged at 6 p.m., she had 2 oral antibiotics, but no idea whether they were for the illness that had prompted her first visit to immediate care, her UTI on her first hospitalization, or the infected elbow. At the rehab center, I'm sorry, this just keeps going on and on. At the rehab center, the nurse reviewed the medications on the discharge summary. Tish's pain medication and sleeping aid were listed as QD, meaning every day. The nurse said QD medications were only given in the morning at the rehab center. Tish protested, explaining that why she needed the pain medication and sleeping aid at night. The nurse said she had to follow orders. The first night, her inability to sleep certainly helped her, though. At 2 a.m., the nurse came into her room and said, "Medicare requires this little prick." Tish asked what it was, and she was told it was a TB skin test. She told the nurse to stop because she's actually a hypersensitive reactor to TB skin tests and should never receive one. The next morning, she received her Ambien sleeping pill and her pain medication for her back. Now, Tish is quite bright, so she actually didn't take her sleeping pill, but of course she hadn't slept all night. Tish developed severe nausea, which either of the oral antibiotics she was on could cause, back from her doxycycline. The rehab unit doctor prescribed an anti-nausea pill over the phone. That didn't help. Susan, Tish's daughter, reviewed her mother's medication with the nurse and found 3 medication reconciliation errors, which the nurse said she couldn't fix without doctor's orders. The orthopedic surgeon's office returned the call about the oral antibiotics. The culture specimens taken in the OR at the time of surgery had been lost in the hospital lab. So the surgeon recommended staying on both antibiotics. No med changes were made. Tish had 2 more sleepless nights. She didn't eat or drink anything because the nausea didn't feel well enough for rehab. Of course, that's why she was there. At that point, the staff decided that Tish was dehydrated again and sent her back to the emergency room after 6 or 7 attempts at starting an IV. An experienced nurse was called and got it in. Already in the rehab center, Tish was in the ER for 5 hours. At one point, an ER nurse chastised her daughter, Susan, for the fact that Tish came to the sunny state, saying, "She's too sick to be bouncing back and forth from Iowa to here." The ER doctor told Tish that her tests were normal and discharged her back to the rehab unit. Susan asked about the oral antibiotics. Remember the 2 oral antibiotics that were making her sick? The doctor said, "Oh yeah, we can stop the doxycycline." Well, if Susan hadn't mentioned anything, there'd still be 2 antibiotics. So this time, Susan made sure the medications were changed so that the sleep aid and the pain pills were given at night instead of the morning, and Tish got different anti-nausea drugs. With this new drug and the discontinuation of the doxycycline, the nausea was gone the next morning. Could have been gone a week ago. The rehab center's medical director actually finally arrived for his weekly visit and agreed to take Tish on as a primary care patient. So she began to eat, she gained some strength, and a week later she was discharged. So more than 3 weeks after the first trip to the immediate care clinic, Tish finally felt better. Despite spending time in 5 different facilities, being stuck more than 20 times, feeling nauseous most of the time, being unable to sleep most of the time, not getting the right medication when she needed, waiting for treatment, waiting for discharge multiple times, repeated scans, lab work, having concerns ignored repeatedly, Tish finally felt better. But her story's not quite over. On the morning of her discharge, she asked the nurse about one of her pills she was taking, and the nurse said, "It's for your blood pressure." She asked the RN to double check it, and the nurse discovered it was omeprazole, which is a medication for decreasing stomach acid. And Tish said, "Well, at least it was given at the right time of day." When Tish got home, she found that a bottle of someone else's medicine had mistakenly been put in her bedside case. Now, the surgeon wanted to remove her stitches, right? Because he did surgery on her a few days ago. But Tish couldn't get an appointment the day she was supposed to come in to get her stitches removed, or the next day, or the day after that, or the day after that. 4 days later, the stitches were finally removed, fortunately without consequence. You know, Tish flew back to Iowa with her daughter and her husband, happy to be feeling better. You know, she told me at the end of this whole thing, she says, what happens if a patient in that situation has dementia? So as I listened to her story, I thought about how poorly she was treated, about all the waste in the system, about all the 8 wastes in the system, right? Which slowed the process, damaged the quality of care, and made Tish's life miserable. So I challenge you. It doesn't have to be this way, right? It doesn't have to be this way, but too often it is. Is this your health system? So here's Tish. If you haven't figured it out by now, Tish is my mother-in-law. This is, she's actually on her porch now in Iowa. And she's a happy, very intelligent, bright lady who can certainly make decisions for herself, but we're put in a position where she couldn't make any decisions. So that's the bad news. You know, what's the problem here? Well, caregivers injured Tish, and this led to complications and tremendous pain. And unfortunately, this is going on a lot around the world in terms of our care of patients. So if that's the problem, what actually can we do about it? What are some of the root causes? And that's what I want to spend a little time on here on the care delivery section of this, or what are the root causes? So here's an interesting map. This is actually a map that Theta Care folks have been working on for over 2 years. And it's a map of what we call the enterprise-wide value stream. Now, we think of Tish's story, right? We're not thinking about that experience through the whole process of the experience of the patient. You know, we're thinking about it from, or we're delivering from the standpoint of the ED, or the inpatient unit, or the surgical suite. But what if we tied them all together? And here's part of the problem. One of the root causes is that if you look at the green boxes here, actually it's the blue boxes. The blue boxes in this cancer value stream, so this is the time from an abnormality is detected to 5-year survival or hospice care, okay? If you look at all of those boxes, 35% is owned and operated by Theta Care, which is a relatively integrated, highly integrated healthcare system. So the point is that, you know, across the enterprise of the patient experience, in many cases, we don't own and operate a lot of the things that are actually important to deliver this care process. That's part of our problem as an industry, is we are not, even though we claim to be highly integrated, we in many ways are not highly integrated. That's part of the root cause. How do we integrate this really complex set of processes? And that's our challenge in healthcare today. One of the other challenges is just awareness. So, you know, is there actually an operating system that could fix some of these problems? It's one of the reasons Len Berry and I published this article in Mayo Clinic Proceedings in January. I highly recommend that you hand this out to your caregivers, because it is about awareness building for fixing Tish's problem. But what I want to focus on for the next few minutes is actually this problem, because this is another part of the root cause of the problem, which is, as Peter Drucker so adeptly said many years ago, most of what we call management consists of making it difficult for people to get their work done. And if you think about Tish's story, the processes of managing the ED and the other components of that care were fundamentally broken. So we got a problem with our management. In fact, I believe the single most important critical factor missing in healthcare organizations today is a management system that actually supports improvement. Most of our organizations are continue to be managed in a top-down autocratic fashion, which quite frankly doesn't work to solve problems. We have to change that. Our industry has to change that. And this is one of the ways that we change it, is we actually start to build a lean management system. So I want to talk a little bit about what that is, because that's what we don't generally spend a lot of time on. So this is John Shook's description of actually how you think about the lean transformation journey. We have the people systems, we have the processes, we have a core set of true north metrics or the purpose. But the thing that we don't focus on is the management system. As you see in this picture, it's beautifully designed that, you know, if you don't have a management system, the whole thing falls apart. And the fact is, most organizations that I visit, it's actually 121 now, Helen, in 12 countries, don't have a management system. So another challenge to you is, do you have a management system that actually supports continuous improvement? I published an article in the spring edition of Frontiers which describes both the management system and the leadership behaviors we require to support that management system. And if you know things are changing, when the American College of Health Executives major magazine has 2 featured articles, one by me and the other one by Gary Kaplan, okay? So I think lean is finally achieving some respect.